Good morning, and first I'd like to thank the Connecticut Challenge for inviting me here today to talk about what's new in exercise and cancer survivorship research. So Mary already presented this slide, but I will reiterate the message again that there is a growing number of cancer survivors, and this is due to our improvement in screening and in treating cancer. So it is a good thing that this number is increasing. However, while improvements in cancer treatment and survival should be celebrated, surgery and treatment are associated with several negative side effects. Common side effects of cancer and its treatment include fatigue, joint pain, lymphedema, peripheral neuropathy, weight gain, cardiovascular disease, diabetes, osteoporosis, poor quality of life, and then on top of that, a risk of recurrence and new cancer diagnoses. And we do know that there's a growing number of research showing that physical activity may prevent or control many of these side effects. So about 6 years ago, the first publication came out looking at the role of physical activity after diagnosis of cancer, in this case breast cancer, and how it may impact recurrence and survival. So this is a study done out of Harvard by Michelle Holmes, where women completed a questionnaire on their physical activity levels roughly about 2 years after diagnosis. And women were then followed for about 5 years until so many unfortunately developed either a recurrence or died of breast cancer or another cause of death. And it was shown that women who were more active about 2 years after diagnosis had about a 50% fewer cancer recurrences than women who do not exercise. And that was about 3 hours per week of a moderate intensity activity, such as brisk walking. And these analyses were controlled for things such as stage of diagnosis, treatment, BMI, and other factors. And so this was really the first publication, and it was just a handful of years ago, showing that something, a behavior such as physical activity could influence cancer outcomes. Similar associations were also observed with breast cancer death and total deaths. So to put things in perspective, exercise is associated with a similar lowering of cancer recurrence risk as chemotherapy and endocrine therapy, or our hormone therapies such as aromatase inhibitors and tamoxifen. However, the exercise data comes from observational studies rather than clinical trials. So the chemotherapy trials, where women or men are randomized to a certain type of chemotherapy versus a more standard of care and then followed, is very well controlled. Where this exercise paper that I had just presented, as well as a number of similar publications that have come out since then, are observational. So where women are just completing these questionnaires and following. So it's strong information, but we need to grow from that with some more clinical trial or more definitive trials that really show how increasing exercise affects cancer outcomes. So while it would be great to look at, randomize women or men with cancer to an exercise protocol versus control and then follow them for recurrence or other outcomes, that's very difficult to do. You would need thousands and thousands of participants from around the country, and would cost a lot of money. So in turn, what we do is we look at what we call surrogate endpoints, or biological markers that we know are strongly related to certain cancer outcomes. So we know that body fat is a strong factor that mediates the relationship between physical activity and cancer outcomes. Also of growing interest right now is insulin, and insulin has been shown to be strongly related to cancer, and the role of physical activity in modifying insulin has been examined. There are a bunch of other biological markers or surrogate markers such as IGFs, or insulin-like growth factors, adipokines such as leptin or adiponectin, inflammatory markers such as C-reactive protein or CRP, sex hormones, the estrogens, and the androgens. And the interesting thing is a lot of these biological or surrogate markers are where certain drugs have now been developed to attenuate or decrease these markers and are now standard of care for men and women with cancer. So for example, women with breast cancer, most of them take an aromatase inhibitor or a tamoxifen after chemotherapy or radiation. And what that does is that decreases estrogen levels or sex hormones. Now it's thought that patients should take metformin, an insulin-lowering medication, which will improve cancer outcomes. So it's important to look at what's going on in our drug development and discovery, and how exercise or lifestyle changes may also work together with those medications to improve outcomes, or for those who don't want to take the medication, what other options do they have available? So highlighting the role of insulin with breast cancer outcomes, this was a study published 10 years ago, and there's been additional publications finding the same, observing the same results, that women, in this case women with breast cancer, shortly after diagnosis from a blood draw looking at the level of insulin on cancer outcomes. So women who had high insulin levels, or in this case defined as in the top quartile, the top 25% of women, compared to women with lower insulin levels, those with the high insulin levels had almost a twofold higher risk of recurrence and a threefold higher risk of death. So, this paper, as well as others, have really sped up the initiation or use of metformin, as mentioned, this insulin-lowering drug, in becoming a standard of care for women with breast cancer. But what else could lower insulin levels? Exercise. And so about 5 years ago, I conducted a study that was done from 2004 to 2008 called the Yale Exercise and Survivorship Study. And the goal of this study was to examine the effects of a 6-month randomized trial of aerobic exercise versus usual care on these surrogate markers of cancer risk and prognosis, such as insulin and IGFs, leptin, adiponectin, inflammation, body fat, and quality of life. And so what we did is we enrolled 75 women from around Connecticut. The average age was about 56 years old, mostly non-Hispanic white women who were inactive at enrollment into the study. That is what we were screening for. We didn't want women who were already currently exercising, because then we wouldn't expect to see any additional change in these biological markers. So the women weren't currently exercising, and they were overweight and primarily stage 1 and 2 breast cancer, and on average about 3 years post-diagnosis. So we randomized women to exercise or to usual care. Usual care being they were provided information on the benefits of physical activity and the importance of it, but we didn't intervene with them. Women randomized to exercise, we paid a gym membership for them, and they had a personal trainer working with them 3 days per week at our local gyms in New Haven and elsewhere. And they were able to increase their exercise to, on average, about 129 minutes per week. The goal was about 150 minutes per week, and so we were just shy of that. And about 75% were doing at least 90 minutes per week of exercise. And so this translated into decreases in body fat, which we measured via DEXA, which is a very objective measure of body fat, and a slight increase among controls. We also observed an increase in lean mass, even though this was primarily a walking intervention done on aerobic exercise, which was walking, treadmill walking, or walking in their community. That weight-bearing activity was enough to maintain or even increase lean body mass, as well as maintain bone mass. And this was an important finding, given about half of the women were taking an estrogen-lowering medication, the aromatase inhibitors or the tamoxifen, which we know aromatase inhibitors will, a side effect of that medication is decreasing bone mass. So the fact that this walking-based intervention was able to maintain bone mass was encouraging. As far as insulin and IGFs, we saw almost an 8% decrease in insulin levels and a slight increase among controls. Similar findings in the insulin-like growth factors. So these are markers of cell proliferation that cause growth of a tumor. So the fact that exercise or walking was able to decrease these markers in just 6 months was also very encouraging. Another study done by Jen Ligabell out of Dana-Farber was conducted at the same time, and her intervention was primarily strength training. It was 2 times per week of strength training with a little bit recommendation of aerobic exercise done on their own at home. And this intervention showed strong decreases in insulin, almost a 28% decrease in insulin levels. And what's interesting is there was no changes really in body composition, no fat loss or weight loss, so that the effect of exercise on insulin is very independent of body fat changes. And so, patients can decide whether they want to do sort of strength training or aerobic exercise or the combination of the two, and that this will have beneficial effects on certain markers related to cancer outcomes. So what these findings suggest is that women can increase their exercise after a breast cancer diagnosis and improve body composition, and that the benefits of exercise on insulin are clinically meaningful. Exercise is also associated with many other improvements such as decreasing adverse side effects of surgery and treatment. So I'm going to now segue into that, the side effects. So we know that with surgery and treatment, there are risks of lymphedema, decreased range of motion, limited use of a limb, fatigue and joint stiffness, with radiation therapy and chemotherapy, as well as endocrine therapy. And the joint pain with the aromatase inhibitors is quite common. This is called arthralgias. And women who are taking AIs, about 50% of them report this joint pain, and it's usually within a month or two of starting the medication. And what they have said is it makes them feel like they've aged abruptly overnight. And the pain is somewhat severe in that they want to stop the medication. And aromatase inhibitors are quite important for women with hormone receptor positive breast cancers and are as effective as chemotherapy. So the fact that some of these women are stopping this medication because of the side effects may not help their risk for recurrence or their prognosis. So it's important to look at how we can improve the side effects of the medication and the therapy, and whether exercise has a role in that. And so we initiated a study in 2009, and this is ongoing. So if anyone's in the audience or knows of women who may be interested in this study, I'd love to hear from you. And this is the HOPE study. And this is to examine in 180 breast cancer survivors, and this is occurring in Connecticut, around the state, the effect of a year-long exercise program on improving the side effects of aromatase inhibitors. So women are taking the aromatase inhibitor and experiencing side effects. The primary endpoint that we're looking at is the severity of arthralgias, or this joint pain. We know from studies of exercise in rheumatoid arthritis or in fibromyalgia or osteoarthritis that exercise may be beneficial for those conditions. So if exercise may improve these side effects in AIs, maybe in turn the women will be more compliant to taking this medication, which in turn will continue to improve their survival. So we're looking at the severity of arthralgias and then the mechanisms of how exercise may improve the joint pain. Is it through pro-inflammatory markers? Is it inflammation? Exercise is decreasing inflammation, and that's what improves the joint pain. Or is it by that they're increasing their cardiorespiratory fitness and their strength, so in turn activities of daily living become easier, and so they don't really feel the pain as much, as well as psychological outcomes. Other side effects of the aromatase inhibitors are bone loss, as mentioned earlier, so looking at how exercise may improve that, as well as some other side effects. So what we do is we enroll women from around Connecticut, and we recruit them. They first come to Yale for a baseline visit. So this is before we randomize them to either group. Once again, to be eligible for this study, the women currently can't be exercising, especially doing a strength training program. If they were already doing that, we wouldn't necessarily expect to see improvements in the outcomes. So women come, they have a DEXA scan, which looks at bone mass and body fat, and we collect a fasting blood sample to look at the inflammatory markers. We then do a treadmill test, or a graded exercise treadmill test, to measure their cardiorespiratory fitness. This is one of our study participants. She looks very happy with that mask on, so that's a good thing. We also measure lymphedema with an objective measure called the pyrometer, and this is a device that you put your arm in and it kind of scans up and down, and it measures, it looks at the volume and the circumference measures of your arms. And so women with breast cancer are at risk for lymphedema. And is it the lymphedema that might be, or the swelling that's causing some of the joint pain? So if exercise can improve the lymphedema, that might be another mechanism. We also measure threshold to pain. And so we use an algometer to test the threshold of pain in certain sites, the knee and the wrist. And then after we collect all those measures, we randomize participants either to our health education or our control group or our exercise group. So if they're in the health education, we discuss breast cancer-related health topics led by a research nurse, or Maura Harrigan. And these are monthly phone calls. And this control group is really to keep them invested in the study, to comply with the study visits. There's a 6-month visit and a 12-month visit, as well as questionnaires that they have to complete at 3 and 6 months. So we don't want to lose these participants, because a lot of them, as you can imagine, get sort of disappointed that they're randomized to that group. But the randomization process is crucial to doing these research studies, and so that we know that any intervention that was done was because of the intervention, and so you need a control group to compare that to. If women are randomized to the exercise group, we purchase a gym membership with them, for them, and then our trainers, who are certified cancer exercise trainers, meet with them twice per week. And what happens is that since these are ongoing recruitment, there might only be about 3 or 5 women at a time during our sessions at the gym. So it's nice. It's more one-on-one training, but it's also small groups where the women can meet other women and help to motivate each other. These are twice weekly supervised strength training sessions, and I believe one of our trainers, Dan Root, is here, and he oversees that, as well as Scott Capozza and Martha Feline, who I think is here. And so these classes are early in the morning or in the afternoon or evening. And then outside of those 2 supervised sessions are aerobic exercise to exercise at the goal of 150 minutes per week. So this is just a picture of some of the study participants, and this is at the New Haven Fitness right on Chapel Street here. And so as far as recruitment, we began recruitment last April, and just to give you an idea of the complexities of enrolling, this is specific to breast cancer, but it would be very similar for colon cancer or prostate or endometrial cancer perhaps. So this is a little bit, this is a month and a half old data, so these numbers have all changed. But as of October 1, we had screened just shy of about 500 patients. And as you can see, they're participants were either not eligible or not interested in participating. But what was really interesting is about over 20%, about 25% of the women were not eligible because they had already stopped taking the medication, the aromatase inhibitor, because of the side effect. Or they didn't even initiate the medication because of fear of the side effects. And so we're sort of realizing that we may be intervening too late, and that perhaps these exercise and other lifestyle programs have to be initiated sooner. These are women that are about 2 years post-diagnosis, and so intervening at the onset of starting the medication may be important for a future study. So as of October 1, we've enrolled about 53 women, and 22 are still going baseline visits. So it's about 70 or 80 women. I think right now we have about 75 women enrolled in the trial. And we will continue recruiting through 2012, and the study will be completed in 2013. This is an example of one of our study participants. So this is the aerobic exercise goal, that 150 minutes per week. We give this information to participants throughout the study to help motivate them on meeting their goals. Because as you can imagine, to be involved in a study for a year and have to be meeting with your trainer a couple times per week can be time intensive. And so this participant exceeded her goal almost for every week of the year. This is the average minutes per week that she exercised. So not all look like this, but about 80% look like this. Monthly we do a timed treadmill walk, a 1 mile timed walk. So they have to walk as fast as they can on the treadmill for 1 mile. And what's great is at the beginning of the study, these women, are average age of 60 years old. None of them have really historically exercised. It might take them 30 minutes to walk a mile. They may have never really stepped on a treadmill before and never owned a pair of sneakers. So this woman in particular, it took about 19 minutes to walk a mile as fast as she could. And then slowly throughout the study, you can see the nice decrease. She was able to walk faster and faster. And by the end of the study, was walking a mile within 14 minutes, which is a very brisk pace. So this is an indirect way for us to measure how they're improving their aerobic exercise. What about changes in strength and body weight? We do what's called a 1 RM, a 1 repetition maximum at the beginning of the study. So these poor women, we take them and some of them haven't been in a gym. They come in and then we tell them all of a sudden, okay, you have to lift as much weight as you can, possibly lift for 1 repetition. And they do it, and then they do it again every 3 months. As you can see, the leg press on the left here, a nice increase in strength of the legs, an increase in leg press, as well as bench press. And this is also associated with a nice decrease in body weight over time for this participant. So it's too early now for me to provide what these, the improvements in aerobic exercise and strength training and body weight, if that translates into improvements in arthralgias and joint pain and bone mass, as well as inflammatory markers, because we'll have to wait till we've done recruiting all the participants. But we hypothesize we're going in the right direction because these factors may mediate the effect of exercise on those outcomes. So, and I'm going to segue into another study that's going on. How do we learn more now about the biological mechanisms through which exercise could affect cancer outcomes? So that study was really more focused on improving side effects, but I have a strong interest in showing that exercise has direct effects on the biology of the tumor. So there's almost no data regarding the effect of exercise on malignant breast tissue. There's limited animal data suggesting that physical activity could reduce formation of chemically induced tumors in rats. So just one or two studies that have taken rats and exercise, chemically induced them with a cancer such as breast cancer, and then had the rats run on a treadmill and then looked at what happened. And this study, published 2 years ago, they randomized 135 rats to either sedentary control or energy restriction, kind of a dietary-induced weight loss, or physical activity. And before the randomization or before the intervention, all the rats were injected with a chemically induced tumor or breast cancer. And what happened is after 1 week, there was a lower incidence of breast cancer among those rats randomized to physical activity compared to sedentary control and energy restriction, and fewer tumors than the other two groups. So this was really exciting research showing that exercise could slow tumor growth, but it is in rats, so not necessarily translatable. So we're actually initiating a study. It's under our IRB approval right now, and we should begin in probably a month, and Martha Fleen is directing this study. And this is where we will examine in women just diagnosed with breast cancer the impact of pre-surgical exercise on tumor markers. So what we're going to be doing is women will have just had their biopsy and unfortunately find out that it's malignant, and then probably in about 4 to 6 weeks we'll either have mastectomy or lumpectomy. And in that time period, during those 4 or 6 weeks, we're going to train them. We're going to train them hard, supervised exercise at our gym, or they'll be randomized to a mindfulness intervention, which I'll explain. What we're going to do is at the beginning of the study from their biopsy, we obtain tumor tissue. And then at their surgery, we obtain more tumor tissue. And we're going to look to see if exercise actually slows tumor growth, as well as other markers related to other tumor outcomes. We'll also look at surgical outcomes. Can exercise improve the surgical outcomes, as well as quality of life? And so women will be enrolled, as I mentioned, to either exercise or to a mindfulness group. And we want to what we're sort of telling the women is we're comparing mindfulness to exercise, because there is a growing literature showing that the mindfulness kind of meditation can improve surgical outcomes and quality of life, but it's unlikely to affect tumor markers. But we feel that that's a good comparison group. And so this will be occurring over the next 2 years. It's a collaborative project with Dana-Farber Cancer Institute, and this will provide really important data to then do a larger multi-site trial that would probably be what we call a neoadjuvant trial. A lot of women with breast cancer might have chemotherapy before surgery, or may take an aromatase inhibitor before surgery to shrink the tumor before surgery. So our goal would be to do a 4-arm trial, say chemotherapy plus or minus exercise before surgery. So this will provide some strong preliminary data. So regarding the pre-ep study, this will provide some of the first data regarding the impact of exercise on tumor tissue. And we think this is very important to move the field forward, to convince second-party and third-party payers to reimburse for exercise programs in the community or at a cancer center or a survivorship program, and to reimburse these activities similar to the way cardiac rehab is reimbursed after a cardiac event. So now I'm going to briefly talk about some other studies of exercise in cancer. Switching from breast cancer, most often breast cancer has been the cancer site that has been examined the most in regards to exercise and diet and other lifestyle behaviors, because it is the most common cancer, and the survival rate is very high, and so it's easy to enroll women with breast cancer into these trials. But what interests me is a lot of the literature from one of my previous studies, we showed that exercise actually didn't favorably affect quality of life outcomes. And it wasn't that it didn't positively affect it, it was just that at baseline, all the women actually had a pretty good quality of life, or it wasn't really different than women without breast cancer. And so it actually didn't need much more improvement. And that might not be the case for all women with breast cancer, and it may differ by stage or age or other factors or your type of treatment. But one cancer that is associated with a very poor quality of life is ovarian cancer. And it struck me that 2 years ago when I submitted this grant that there was no literature published on the role of lifestyle factors influencing ovarian cancer survivorship, and particularly quality of life outcomes and fatigue outcomes. And this is a population of women that when diagnosed, 75% recur or die within 3 years. So their quality of life is significantly impaired. And usually some of them start chemo and never go off it for the duration of their life, which also, of course, affects their quality of life, as well as fatigue levels. So we started a study about 1.5 years, 2 years ago, to examine the effects of a 6-month home-based moderate intensity walking program on factors associated with ovarian cancer prognosis and survivorship. And this is in 230 women around Connecticut, and we've actually now opened it nationally, and we're also partnering with Memorial Sloan Kettering, Mary McCabe and other colleagues there, Elizabeth Jewell, and also with Dana-Farber and UPenn. And then I'll mention briefly how we've kind of opened this nationally. So if you know of any women with ovarian cancer that would be interested in participating, I'd love to talk with you more about this. So what we do is we enroll women anywhere from about 6 months to 4 years post-diagnosis. 6 months because if we enroll them too early after their diagnosis, the surgery and the initial bout of chemotherapy may be a bit overwhelming, and it might not be the most appropriate time to intervene. In fact, our first year of recruiting, when we recruited women about 2 to 3 years post-diagnosis, we actually had a higher enrollment rate than women diagnosed within a year, meaning that maybe they'd be more receptive to survivorship or exercise or other lifestyle programs about 2 years after diagnosis. And so we enroll women and we collect some baseline measures, questionnaires, looking at quality of life, fatigue, and peripheral neuropathy. A lot of these women have never even heard the term peripheral neuropathy, and they definitely don't think lymphedema applies to them. They think, oh, isn't that only with breast cancer? But you're actually removing all the lymph nodes in the lower body, so they are at high risk for lower limb lymphedema. So we measure that as well with the pyrometer, which I showed earlier. We also we collect a blood sample at the beginning and the end of the study to look at some of these surrogate or biological markers in the blood, and if exercise can improve those markers of ovarian cancer. And what we chose to do is to make this intervention home-based, given that some of these women are still undergoing chemotherapy or they might go back on it. And because there's only about 300 women diagnosed per year with ovarian cancer in the state of Connecticut, we had to be able to reach women all over the state. So it wasn't feasible for us, nor for them, to come into a gym. So what we do is Linda Gottlieb, who's our certified cancer exercise trainer, she calls the women weekly and motivates them to exercise, and she works her magic. She tells them how to track their exercise, how to plan it, how to, opportunities in their community, and she's been amazing in getting these women who, once again, have really never exercised, and they're exceeding the goal being 150 minutes per week of brisk walking. And I don't know how she does it, but she's doing it with almost all the participants. So in this study, women are randomized to exercise with these weekly telephone calls, which are about 20 minutes in duration, or to our health education group, which also has a weekly phone call for about 20 minutes. And the importance of having the control group be matched on time, matched on how much time is given to the exercisers is very important, because when we submitted this grant for funding, a couple of the reviewers said, well, is it the phone call and the fact that the patient has someone to talk to? Is it 20 minutes a week? It might not seem like a lot, but for some patients, talking to someone who's involved in ovarian cancer research, that might be enough in and of itself to improve fatigue or to improve quality of life. So we needed to compare, phone calls talking about, say, health education topics to a group with talking about health education topics plus exercise to show that it's exercise above and beyond the weekly phone call that can improve the quality of life, fatigue, and other ovarian cancer outcomes. So both groups really are getting an intervention, and I think women are very happy with either group that they're randomized to. So now switching kind of back to breast cancer, the LEAN study, this is really looking at weight loss. We know that weight at diagnosis is a strong predictor of recurrence and death, and that unfortunately women tend to gain weight during treatment or after treatment, especially with some of these hormone therapies. And so that weight gain, independent of body weight or BMI at diagnosis, can have an adverse effect on their outcomes. And there's really been few weight loss trials, randomized trials, in breast cancer survivors or any population looking at how weight loss may improve cancer outcomes. And so Maura Harrigan is the project director on this study, and this study we're looking at a couple aims. We believe that it's important to have more research done in this field, but we also think that the observational data is strong enough regarding the role of weight or BMI and cancer outcomes. So we want to be able to roll this out in the community or within our cancer center here in a cost-effective way. So what we're doing is a 3-arm trial where we're comparing in-person weight loss counseling to telephone weight loss counseling to usual care. And we hypothesize that the telephone counseling would be as effective in the amount of weight lost and changes in other biological markers as the in-person counseling. And so this allows us to then reach women throughout the state or even nationally with these programs. And so in turn, community-based programs can offer these resources in a cost-effective way. And in fact, Maura has really mentioned a lot the pros and the cons of both groups. She has done some of these telephone interventions, it's a 6-month intervention where there's about 11 sessions over 6 months. So it's almost like every other week that she calls these women or meets with them in person. And they're a 30-minute session. She keeps to the 30 minutes. We developed a really nice workbook that guides each of the sessions on how to favorably change your diet and increase your exercise to lead to a weight loss. And she's done some of these telephone calls in her car, and the participant might be in Paris or something. And so there's definitely strengths or pros to doing telephone-based interventions. Where in person, the benefits of that is she's able to see the participant and maybe affect them with that in-person interaction a little bit better. So this study will be ongoing through next year, and we are recruiting participants. So other studies outside of Yale or around the country, the field of exercise and cancer survivorship is really in its infancy. It's only about 5 years now that there have been more studies really looking at the role of exercise on more of these cancer outcomes or biological markers. The earlier research, but only about 10 years ago, was really looking at the quality of life endpoints in only really breast cancer survivors. So now the field is really going forward with how do we work with the treatments that are currently being offered to patients, how exercise may improve it, or is exercise an option instead of some of the endocrine therapies or whatnot. So there's an NCI initiative called TREC, Transdisciplinary Research on Energetics and Cancer. And they have funded multiple sites around the country to do research related to exercise, weight, diet, or energy balance and cancer. And so a couple studies done. So Dana-Farber is one of the sites. And they have a 4-arm trial of exercise and metformin, this insulin-lowering medication. So it's either exercise alone or the medication alone or the combination or the usual care group. And this is in men and women with colon cancer, examining how exercise with or without the medication may improve some of the insulin and insulin-like growth factor endpoints. At Penn, which is also part of the TREC initiative, Katie Schmitz is looking at the role of weight loss and exercise on lymphedema. Her earlier work really published about 2 years ago showing that strength training improves risk of lymphedema or among women with lymphedema, exercise can decrease the number of flare-ups. And so that her previous work was really focusing on the role of exercise. But we know that weight is a predictor of lymphedema. So women who are heavier are at a higher risk of developing lymphedema. And so she's doing a 4-arm trial of diet with or without exercise. So exercise alone, diet alone, the combination on lymphedema. Some other exercise trials, Nina Kaden-Loddick is really interested in looking at the role of exercise in pediatric oncology patients here at Yale, and looking at if exercise can improve fatigue and cardiorespiratory fitness, cognitive impairment, body composition levels in boys and girls diagnosed with various cancers. There hasn't been a lot of research in prostate cancer and colon cancer, so there definitely needs to be more research done in that area, as well as endometrial cancer. So where has the research that's been done to date led us? What are the recommendations now going forward regarding exercise? Last year, we put out exercise guidelines for cancer survivors, and what we did is the Department of Health and Human Services in 2008 published a physical activity guidelines for healthy adults or healthy Americans. And so we looked at that consensus statement and thought, okay, how do we have to modify this or adapt this for men and women diagnosed with cancer? And so we actually, in the end, it's very similar to those recommendations with few modifications here or there. And the first goal or recommendation is to avoid inactivity. We know that for some people it's hard for them to find time in their daily schedule to actually do exercise. And so one thing is avoiding inactivity, avoiding your sedentary time. There's a lot of research going on in this area. If just decreasing your sitting time and just being more busy actually improves outcomes. Returning to normal activities as quickly as possible after surgery. Continuing normal activities and exercise as much as possible during and after treatments. And then the 150 minutes per week of moderate exercise or 75 minutes per week of vigorous exercise. Strength training 2 times per week. For metastatic patients, this requires some modifications and perhaps more supervision, as well as patients with cardiac findings. So when we developed these guidelines, we thought it was very important to make it clear that if a man or woman diagnosed with cancer wanted to start an exercise program, that he or she did not need like a physician referral it did not require medical assessments for all survivors prior to exercise. This was not recommended. We felt that for some cancers, such as breast cancer, the prognosis is really good, and so 1, 2, 3 years after diagnosis, there's no reason that they can't join a gym and start an exercise program on their own. And that if we make a clinician referral mandatory, then that might impede their starting an exercise program. However, as I'll show you in slides to come, we do think it's very important that these patients seek out certified trainers to help them adapt or modify an exercise program. So some site-specific medical assessments that should occur prior to exercise for breast cancer, evaluating arm and shoulder morbidity and lymphedema. And if there's no problems, then they can, if there are problems, then they shouldn't do upper body exercise right away, or they should really definitely work with a certified trainer who knows how to make the strength training program work slowly and more progressive. Prostate cancer, really evaluating for muscle strength and wasting because some of the medications they take may be related to bone loss as well as lean body mass. Similar with breast and prostate is the evaluation for fracture risk because of the medications. Colon cancer infection prevention for patients with an ostomy. In that case, seeking physician permission is probably recommended. For gynecology, evaluating for lower extremity lymphedema, so that's ovarian cancer and endometrial cancer. And then for all cancers, evaluating for peripheral neuropathies. If there's tingling or no feeling in the toes, then really being careful on a treadmill or other types of weight-bearing exercises. Not to say you can't do these, but just being aware of them. So some contraindications for starting an exercise program: you want to allow adequate time to heal after surgery. Do not exercise patients who are experiencing extreme fatigue or anemia or metastatic disease. But then following the ACSM guidelines or the American College of Sports Medicine guidelines regarding some cardiopulmonary contraindications. So the goals of any exercise program would be to regain and improve physical function, aerobic capacity, strength, and flexibility. Knowing that probably a large percent of the population has never really exercised, but some, 25 to 30%, really were active before their diagnosis, and their goal is to get back to that. To improve the quality of life and anxiety regarding recurrence, improving body composition, and reducing or delaying the recurrence or second primary cancer, and reducing or preventing any long-term or late effects of cancer treatment. So how to apply this to practice? Providing clear instructions to exercise and avoid inactivity, reassure the patient that exercise is safe, and instruct the patient to exercise at least every other day to build up to the 30 minutes, progress slowly, moderate intensity or vigorous, and choose an activity they enjoy. So some of the other side effects that you want to pay attention to, I already kind of mentioned this, but with the lymphedema, how to start an exercise program, especially a strength training program. You have to really make sure that you start with at a very low weight and you progress at the smallest increment possible. Peripheral neuropathies, consider using weight machines rather than free weights, and spotting the client. Those with a decreased range of motion, focus on increasing the range of motion, and fatigue, starting slowly and increasing intensity and duration gradually. So a lot of this information is actually what is covered in a new certification exam that the American Cancer Society and the American College of Sports Medicine came together to develop this certification exam. And there were about 10 experts from around the country where we developed this certification exam. And this is available to any fitness professional, exercise trainer, physical therapist, nurse, or anyone interested in working with patients diagnosed with cancer. And you can take this exam at any kind of testing facility. And my hope is that more and more trainers will get certified, and that in turn maybe insurance will reimburse for these programs where patients or survivors are training with those certified exercise trainers. And I know there's a handful in the room who are certified. Just out of curiosity, if you have this certification, would you raise your hand? Okay, great. So there's about 6 people, I think, in here. So that's great, and that's in the state of Connecticut. My other goal is that all oncologists or surgeons would refer their patients to these certified trainers. And so, on there could be a website, I think the Connecticut Challenge is moving forward with this, where the oncologist could type in the patient's zip code, and then a list of certified trainers would come up, and they could refer their patients to those trainers. So one thing I've worked on this past year is that there really wasn't any sort of textbook to study for this exam. And then once passing the exam, how to make sure you really are developing the appropriate exercise program or adapting it or modifying it based on that person's medical history. So I've worked with the American College of Sports Medicine, and this February will be published a guide to exercise and cancer survivorship, which is sort of like a test book for this exam, but also for the cancer survivor or the allied health professional or fitness professional to learn more about exercise and cancer survivorship. So that will be, information on that will be on Amazon and the Human Kinetics website. So what is this exam hopeful to do? The goal is to increase the knowledge and ability for the certified trainer to discuss cancer diagnosis, treatment, and side effects, to understand the impact of cancer treatments and the risk of injury and complications, to discuss the benefits of exercise, select appropriate programs, evaluate adverse responses to exercise training and how to modify the exercise program, and of course, most importantly, when to seek clinical consultation for the client during or following treatment. We make it very clear that this fitness professional is not a medical oncologist or surgeon, and that he or she needs to know when it is appropriate to to seek that clinical consultation. We also make it clear that this trainer is not a registered dietitian and should be limited on the amount of counseling they do on dietary change or related to their diagnosis. And so to seek out the registered dietitians who are certified in this as well. So what do we do at Yale? So, taking all this research and some of the work that's been disseminated, what's the model that we've used here? So we were very fortunate about 5 years ago to receive funding from the Connecticut Challenge to open our survivorship clinic here at Yale, which was founded in 2006. Ken Miller really kind of shepherded it through for the first 4 years, and now Tara Sampt is the director of our adult survivorship clinic. And what typically occurs is that after a patient completes treatment, hopefully, the oncologist or the surgeon is referring that patient onto our survivorship clinic. And this clinic was really based on sort of a one-time visit that is in the afternoon. So it's about a 3 to 4 hour long visit where they meet with the oncologist or the APRN, Tom Quinn, and they do an end of treatment summary report and survivorship care plan. The patient then sees Maura Harrigan for nutrition or weight loss counseling for about these are all 30 to 45 minute consult visits. And then sees Scott Capozza about any kind of physical therapy, range of motion issues, as well as developing an exercise program. And then Lena, who is a social worker and counsels on back to work issues, marital issues, sexual issues, and all that. So these visits occur over a 3 hour period, and then there is, they can come for a follow-up visit or two, probably 2 months afterwards, to see if they have been able to change their lifestyle, change their eating or exercise habits, or concerns regarding screening for future cancers. So we've found that on average, we're seeing about, I think we've seen over about 400 patients over the last 500 years, and we haven't been able to really see what this translates as far as a risk of recurrence or survival, but Tara will be examining that and how it is associated with improving screening mammography, how it may improve knowledge of side effects so that you can intervene earlier to attenuate the side effects associated with the treatments. So in conclusion, I hope I've presented to you really a lot of the research going on regarding exercise and cancer survivorship. And some people think, oh, how can you intervene with exercise after diagnosis? They have so many other things going on. But in fact, a lot of patients will say that their diagnosis is a teachable moment and patients are willing to consider lifestyle changes. Exercise is associated with improvements in side effects, biological markers, and recurrence and survival. That has been from observational studies with recurrence and survival. So we really need to confirm that in clinical trials where we randomize to either weight loss or to exercise and follow them for recurrence outcomes. We also have to look at these other understudied cancers, the ovarian cancer, endometrial, prostate, and colon. And we need to examine associations and interactions among lifestyle, environmental factors, as well as genetic factors on risk and survival so as to better prevent cancers in the first place, better screen them, and then better treat patients. So in closing, I'd just like to acknowledge some of the funding sources, as well as my team here at Yale. I couldn't do any of this research without them. So I'd like to acknowledge Brenda Cartmel, Bitsy Ercolana, Maura Harrigan, Scott Capozza, Linda Gottlieb, Yang Zhou, Mariana Rothbard, and others. So thank you very much.